Hi, good evening, everyone. Welcome to APSC Hot Topics in Cardiology webinar series, episode 5. So can you see my slide? Yes? Okay. So today we will focus on hypertrophic cardiomyopathy, and we will cover a wide range of topics from genetic background to clinical management. So I'm Misato Chimura from Japan, and I will uh, I will I will be moderate today's webinar together with Dr. Ezman Shariff. Thank you very much for being with us. And we are very pleased to have two excellent panelists with us today. So Dr. In-Cheol Kim from Korea and Dr. Masashi Amano from Japan. And we're honored to welcome two distinguished speakers, Dr. Takashi Hiruma from Japan and Dr. Yuan from Singapore. So before we begin, we have disclaimers and housekeeping items. The content of this webinar is copyrighted by the APSC. The view and opinions expressed are those of faculty members and do not represent those of the APSC. This webinar is live streamed by APSC Facebook and YouTube pages. You will receive your certificate of attendance on completing a survey sent by email post-webinar. If you have any questions, please submit them using the Q&A function on your screen. As time is limited, we would appreciate it you could post your questions during the presentation. And we would like to take the opportunity to remind you the APSC conference will be held in Taipei from May 14 to 17, 2026. The abstract submission deadline is February 15th, so there is still a few days left. We encourage you to submit your abstract if you have not already done so. Then our next webinar will take place on Wednesday, March 18th at the same time. The topic will be arrhythmias, and we hope you will join us again next month. Now, let us begin today's program. Our first presentation will be given by Dr. Takashi Hiruma from Japan. The title is Genetic Architecture of Hypertrophic Cardiomyopathy in Asia-Pacific Populations. So, Dr. Hiruma, when you are ready. Okay, please begin. Dr. Hiruma, microphone is off, so please.
I'm sorry. I'm sorry. Good evening, everybody. It's my pleasure to have the opportunity to present at APSC Hot Topics in Cardiology webinar. My name is Takashi Hiruma from the Department of Cardiovascular Medicine, the University of Tokyo. Today, I will talk about genetic architecture of hypertrophic cardiomyopathy in Asia-Pacific populations. A short self-introduction. I expertise in genetic analysis and catheterization for HCM patients. And my previous studies on HCM mainly focusing on genetic analysis and alcohol receptor relation. Today, I prepared 3 topics: the genetic architecture of HCM and genetic testing in the clinical practice and key findings from Asia-Pacific regions. Okay, let's start from genetic architecture of HCM. The HCM is an inherited cardiomyopathy characterized by asymmetrical septal hypertrophy and myofibril disarray. Its prevalence is estimated up to 1 in 500 individuals in the general population. The HCM patients exhibit a wide range of clinical manifestations, including lethal arrhythmias, atrial fibrillation, and progressive heart failure due to obstruction, and end-stage HCM caused by left ventricular systolic dysfunction. The beginning of the study for unveiling the genetic architecture of HCM is back to 1961. The first study of familial cardiac trophy was demonstrated. And 30 years after, the first variant was identified in genes, MYH7 gene, which encode cardiac myosin heavy chain. And 6 years after, the variant was validated by using animal model. This animal model completely replicated human HCM patients' cardiac hypertrophy, myofibrillary artery, and fibrosis. Thereafter, a large number of variants were mainly identified in genes encoding sarcomere proteins. And sarcomere is the smallest structural unit of cardiac muscle. And to date, 9 major sarcomic genes have been definitively associated with disease onset of HCM. These genes encode myosin heavy chain, myosin essential light chain, regulatory light chain, and myosin binding protein C, and actin, tropomyosin, troponin T, I, and C. Genetic testing can identify pathogenic sarcomic variants in approximately 30% to 60% of HCM patients. And the most affected variant gene is MYH7, followed by MYBPC3, TNNT2, and TNNI3. Therefore, HCM has been considered as a sarcomic disorder caused by pathogenic sarcomic variants. Okay, let's move on to the genetic testing in the clinical practice. So at the beginning, I want to introduce the flow chart of genetic testing. The genetic testing is composed by 5 steps: the sample collection, sequencing, variant calling, annotation, and evaluation of pathogenicity of the variant. The last step is in accordance with the consensus guideline from ACMZ. Criteria include allele frequency, enrichment in cases, co-segregation, impact on protein function, in silico prediction, and functional analysis. Based on the adaptation of the criteria, the variant pathogenicity is classified into 5 grades: pathogenic, likely pathogenic, uncertain significance, likely benign, and benign. In general, the variants classified as pathogenic or likely pathogenic were defined as pathogenic variants. So the next step is understanding the utility of genetic testing in clinical practice. The first utility is cascade screening. If the proband was identified pathogenic variant, their family members should be conducted genetic testing to confirm inherited patterns and to identify asymptomatic carrier of the variant who should be followed up. Because as shown in this cumulative incidence of penetrance, during the mean follow-up of 15 years, approximately 50% of variant carriers develop HCM. The second utility is differentiation from HCM phenocopies. These include Fabry disease, Danon disease, PRKD syndrome, amyloidosis, and Noonan syndromes. These phenocopies share cardiac hypertrophy, but their pathophysiology is significantly different from sarcomic HCM. And majority of these phenocopies is caused by pathogenic variants in specific genes. Genetic testing can clearly distinguish HCM from phenocopies. In our previous study, we reported a case of end-stage HCM, later identified as PRKD cardiomyopathy by conducting genetic testing. The third one is potential utility in risk stratification. So there is a lot of emerging evidence in this field. Okay, so for the first of all, we have to understand the genotype-phenotype correlation in HCM. As shown here, genotype-positive HCM patients who are diagnosed with HCM at younger age and have a high burden of family history of HCM and sudden cardiac death. And they exhibit severe hypertrophy with reversed curved septum and less hypertension. Regarding the prognosis, the incidence of fatal arrhythmia atrial fibrillation, and severe hypertrophy, heart failure composite, frequently observed in genotype-positive HCM patients. And among genotype-positive HCM patients, there is a specific genotype-phenotype correlation have been reported. For example, if HCM patients have thin filament variants, they exhibit more severe diastolic dysfunction, concentric hypertrophy, and extensive fibrosis, and they are at a high risk for the progression to end-stage HCM. On the other hand, the thick filament variant carriers exhibit obstructive HCM. And when compared between carriers of MIBPC3 variants and MIHCM variant carriers, the incidence of new onset AF is significantly high in MIH7-mediated HCM patients. And in contrast, the progression to end-stage HCM is more frequently identified in MIBPC3-mediated HCM patients. And importantly, approximately 5% of HCM patients carried multiple variants in sarcomic genes, as shown in the example case, truncated variant in MIBPC3 and missense variant in TNNI3. And these patients exhibit a poor prognosis compared to those with a single sarcomic variant. So as described here, the HCM patient prognosis is largely determined by presence or absence of pathogenic sarcomic variants. But if patients have the same variant, they exhibit phenotypic diversity. So risk stratification based on solely sarcomic variants is not sufficient. So recent study performed comprehensive genetic testing for the further risk stratification of this population. And several genetic modifiers was identified, such as common variants and other CVD-related variants and somatic variants. Today, I would like to focus on other CVD-related variants, which we previously studied. And genetic testing in HCM can identify sarcomic variants, but not only sarcomic variants. The variants associated with other CVD cardiovascular disease can be also identified in HCM patients. For example, DCM-related variants, arrhythmogenic cardiomyopathy-related variants, aerobic compaction, and arrhythmias. However, they have never been highlighted because they are not the primary cause of disease onset. So whether they act as just a bystander or modifier remains uncertain. So in a previous study, we conducted comprehensive genetic testing targeting 83 genes, including sarcomic genes and other cardiovascular-related genes, to assess the impact of other CVD-related variants in HCM patients. The study endpoint was the progression to end-stage HCM, one of the most malignant phenotype in HCM. This is a summary of the study. A total of 378 patients were included, and 139 patients had pathogenic sarcomic variants. Of these, 11 patients had other CVD-related variants. For example, truncating variant in Taichin and missense variant in filament C. And importantly, these patients, those with both sarcomic and other CVD-related variants, exhibited a higher incidence of the progression to end-stage HCM compared to those with a single sarcomic variant. From our findings, we propose a concept that the coexisting other CVD-related variants are not just bystander, but act as modifiers of phenotype and clinical outcomes of sarcomic HCM patients. And our study was created in the latest HA statistic update. And as described here, it is important to comprehensive genetic screening beyond conventional sarcomic genes for the further risk stratification of HCM patients. Again, the presence of pathogenic sarcomic variants plays a central role in HCM prognosis. And in addition to this, coexisting other CV-related variants and other genetic modifiers also forms the HCM prognosis. So comprehensive genetic testing is important for accurate diagnosis and further risk stratification in this population. So genetic testing in clinical setting is useful for cascade screening, differentiation from phenocopies, and risk stratification. Okay, at the last of my presentation, I'd like to introduce key findings from the Asia Pacific regions. To date, a lot of studies have been reported from APSC member countries, and they have revealed both shared and population-specific characteristics of HCM genetics. I want to introduce all of these studies, but I do not have enough time today, so I picked up several studies. The first one is the shared genotype-phenotype correlation. The study was reported from South Korea. As shown here, distribution of the affected genes and HCM-related endpoints in genotype-positive patients inconsistent with previous studies reported in Western countries. Such similar findings have been reported from other APSC members. The second point is specific risk areas in Asia-Pacific population. For example, the missense variant in TNNT2 and missense variant in TNNT3. These variants are absent in European population, but commonly observed in general population in Asia. According to the guidelines, these variants are classified as benign or likely benign. However, a recent study from recent HCM cohort study from Singapore reveals that these variants were significantly enriched in HCM patients. This means that these variants are not pathogenic, but they act as risk areas of disease onset of HCM. So what I want to say is summarized in this study, in this slide. This is a comparison of pathogenic variants and risk variants. Pathogenic variants is rare in general population, and they have enough effect size for the disease progression. On the other hand, risk variant is commonly observed in general population, and they do not have enough effect size of their own for disease progression to HCM. However, they were combined with aging, lifestyle, comorbidities, and environmental factors. Risk variants can act as substrate of disease onset of HCM. So we should not discard the population-specific risk variants as just benign variant. The third point is genetic background of apical HCM, a common phenotype in East Asian. This phenotype is characterized by apical hypertrophy with giant negative T wave. Genotype positivity is significantly low in this phenotype. That a recent study performed deep phenotyping and proposed that the apical HCM can be divided into two subtypes, a pure apical form and distal dominant form, with hypertrophy expanding proximal to the papillary muscles origin. Interestingly, genotype positivity is significantly different amongst these phenotypes. And regarding the prognosis, distal dominant form is significantly associated with a poor prognosis. So for the better understanding of genetic background of apical hypertrophy, deep phenotyping and comprehensive genetic testing is important. And the detection of a novel causative gene has been reported from Asian Pacific regions. The gene name is KLHL24. This gene encodes KL-like family member 24, a ubiquitin ligase substrate receptor for desmin in cardiomyocytes. The genetic testing in familial HCM from Iran detected homozygous nonsense variant in KLHL24. And pathological examination demonstrated no disarray, but significant deposition of desmin in cardiomyocytes. after the validation using small animal models, this variant was proven to have moderate evidence for the disease onset of HCM. And now it is curated as HCM causative gene from expert panel of HCM. Okay, at the last of my presentation, I would like to propose a challenging in Asian Pacific population. There is a distinct detection rates of variants. The share registry, the largest genotyped HCM patients, consistent with Western countries, reported that the detection rate of pathogenic or likely pathogenic variant was 46%, and uncertain significance was only 9%. In contrast to this, the studies reported for Asian Pacific populations consistent with a relatively small sample size and relatively low detection rate of pathogenic variant and high burden of uncertain significance. This may be due to the lack of a large-scale comprehensive genetic analysis in our population. Because to determine the variant pathogenicity, it is important to evidence is important, but if this evidence is not enough, variant pathogenicity result in uncertain significance. So it is important for the accurate interpretation of the pathogenicity of the variant to perform comprehensive large-scale genetic testing in our population. And it is time for us to incorporate each other. Okay, take-home message. Genetic testing is useful for cascade screening, differentiation from phenocopies, and risk stratification. While sarcomeric variants play a central role in HCM prognosis, comprehensive genetic testing is warranted for further risk stratification. And the Asia-Pacific population has a distinct genetic architecture. So large-scale comprehensive genetic studies are encouraged in this population. That's all for my presentation. Thank you for your attention.
So thank you so much. Great presentation, Dr. Hiruma. So you provided a comprehensive overview ranging from how to perform genetic testing, how to apply genetic testing result in everyday clinical practice, to regarding genetic mutation in HCM within the APSC. So thank you so much. So if the audience have any questions, please using the Q&A box to send it to us, please. So I have one question for you, okay? Uh, so do you see differences in the prevalence of sarcomatic genetic variation between Asia Pacific and Western populations? What do you think? So if we have, so how should we understand these differences? So do you think that reflect true biological or genetic differences, or could they be related to the difference in the study design, patient selection, or available data? What do you think?
Thank you for your great question. Regarding the prevalence of pathogenic detection rate of pathogenic variants, it is relatively low in Asian Pacific population compared to Western countries. It is in previous studies from Western countries, it is reported to 40% to 60% of HCM patients have pathogenic sarcomeric variants. But in Asian Pacific population, it remains only 20% to 30%. So the reason for these differences, one of the potential reason is, as you described, biological differences. And in addition to this, the more important point is that lack of enough evidence to determine the pathogenicity of the variant in this population, because previous studies from Asian Pacific population is relatively small sample size, so we cannot determine the enrichment of the variant in HCM patients, and cascade screening is lacking, and functional analysis using animal model or human cardiac tissues largely absent. So the variant pathogenicity lacks evidence, so result in uncertain significance. So it's lead to the low rate of detection rate of pathogenic variants in this population, I think. Thank you.
So much. So Dr. In-Cheol Kim. So
Hi,
do you have okay, yeah.
Yes, I
Can you-
have one comment and a question for Dr. Takashi Hiruma. Thank you very much for your wonderful lecture, and it was really insightful, and I could learn a lot from your lecture. And I totally agree with your opinion that we should work together to build an evidence in the Asian Pacific population to confirm that there are so many variants of unknown significances, but we should confirm that whether they are likely or pathogenic. So I think I totally agree with your opinion. And I have one comment and question regarding the apical HCM. Apical HCM, we see a lot in Asian population, and mostly they are considered as benign form. But as you have mentioned, if it is extended to a little bit more to mid or base, a little bit extended more than apex, like mid segment, you call that distal dominant. The article mentioned that it's distal dominant, which was seen more genetic variants in those types. But in my opinion, it's very, sometimes it's difficult to distinguish whether it's only confined to apical or it's extended to a little bit more. So in my opinion, I usually prescribe cardiac MRI to our hypertrophic cardiomyopathy patients. And if the apical hypertrophic cardiomyopathy patients has late gadolinium enhancements, I feel like I don't have any data, but I feel like they do worse in terms of their outcome, and they tended to have more genetic variants. So I think it's one clue that we can pick up pure apical or benign apical or distal dominant, or maybe more extended apical pattern of those hypertrophic cardiomyopathy types. So, but for evaluating hypertrophic cardiomyopathy patients, I think it's better to perform, of course, genetic test. It's important, but multimodality imaging test, including cardiac, maybe CT or cardiac MRI, it's crucial to distinguish whether the patient is in high risk or they are they have much less risk. So I would like to ask your opinion on this insight.
Thank you. Thank you for your great suggestion and a grateful comment. I totally agree with you. Genetic testing is important, but much modal imaging evaluation using CT or cardiac MRI is also very important to for the better understanding of phenotype of its deep phenotyping of HCM. And in the clinical practice, such multimodal imaging is very important for decision making in patient therapy. Indeed. For example, cardiac MRI is very useful for detect not only hypertrophy but also intracardiac, left ventricular abnormal septal bundles or an abnormality in mitral valve index complex. So they directly affect our decision making in treatment therapy, for example, septal reduction therapy or something. So genetic testing is now emerging and getting evidence for the clinical practice, but it is important to combine with genetic testing and comprehensive multimodal imaging, I think. Thank you so much.
Thank you.
So Dr. Masashi Amano, do you have any questions and comments?
Yeah, thank you, and very nice. Thank you for your very nice lecture. And I feel the genetic testing in HCM is very deep compared to Fabry, Denon, and ATTR amyloidosis. My concern is performing genetic testing in clinical settings. First, the guidelines in the US is genetic genetic testing is the first step for screening. But in Japanese, considering the Japanese circumstances, it's not the first step because of the national characteristic or ethical problem or the poor establishment of genetic counseling. And this is because the low percentage of pathogenic positive rate. So how do you select the patient for performing genetic testing in clinical setting? And the second question is I want to ask the other doctors in other countries. So how about the genetic testing in the Asian countries? The what stage do you perform genetic testing?
Thank you for your very nice, great, important question. Regarding the first question about how to select the patient who should be conducted genetic testing, one of my opinion is that those who have family history of HCM and sudden cardiac death, severe hypertrophy, or reverse curve septum, all of which characteristics of genotype positive HCM patient. And as you mentioned, it is not reality to perform genetic testing for all outpatient HCM patients. So in fact, genotype prediction score has been reported from Mayo score 10 years ago, and this consisted with early disease onset, family history of HCM, sudden cardiac death, septal morphology, and severity of hypertrophy. And adapting this pre-genetic prediction model, we can select patients who should be conducted genetic testing, I think. And we modified this Mayo score in the recent study, which are not yet published, by combining electrocardiographic findings. For example, with the presence of atrial fibrillation and conduction disturbance and the lack of left ventricular hypertrophy amplitude.
Should I also chip in? Because I think Dr. Amano had mentioned the other Asian countries as well. And I've got a few people messaging me now to ask the same question about Malaysia. So in Malaysia, it's close to non-existent because it's pay out of pocket, so it's not fully reimbursed. There are ways to do or perform genetic testing. You can perform both either very targeted genes or whole genome sequencing, and I think we all know gold standard is WGS, but of course the cost is more. There are some institutions who do embark on genetic testing, but at this point in time, still fairly academic, I think. Treatment-wise, wouldn't change as much. Transplant is not very big. ICD insertion or implantation isn't as big as other countries as well. But as Dr. Kim had mentioned as well, I think we are mainly with multimodality imaging. So we do a lot of imaging, echo, and then MRI, find the late gadolinium enhancement, maybe risk stratify that way. Whole genome sequencing, though, I think is the way forward. I'm quite happy that Dr. Hiruma had mentioned a very important point on modifier genes, which we sometimes take for granted. And if those genes actually do play an important part, then really we shouldn't be doing targeted genes. We should be doing as many genes as possible. But of course, cost implications should be considered. At least that's for Malaysia. I'm not sure about Singapore, CY. What is it like in Singapore?
So for Singapore, we have a group of patients who have gone for research studies where they had genetics done as part of a study. Now we also have at least in my center and most of the centers in Singapore, we have a cardiogenetics clinic where we refer the patients with cardiomyopathy for genetic counseling and genetic screening. So as what our speakers have said, we don't really refer all our patients because we do have quite a number of them. So mostly we go by clinical, that means the younger patients with more severe phenotype, those with family history, especially those with family history of sudden death, then we counsel them for genetic screening. Now we also counsel young patients because there may be an option of pre-implantation genetics if they have the gene identified. Yeah, but the uptake is still pretty low because most patients are still quite cautious about checking their genes and they are fearful of implications on insurance and things like that still.
Probably ask our Korean colleague as well, Prof. Kim, how is it like in Korea?
Yeah, in Korea, we follow this similar strategy. So we selectively do genetic tests because it's not fully reimbursed. It's partially reimbursed, actually. We have NGS and cardiomyopathy next generation sequencing, which I prescribed mostly. And the cost would be like $500 for a test. So it's not, yeah, it's not easy to perform, not a daily, easily applied test. So yeah, I follow this similar strategy.
Yeah, thank you for answering. So, to tell the truth, in Japan, a lot of patients refuse performing genetic testing because of nationality or risk problem, and clinicians struggling for hard follow-up with patient with VUS or negative genetic testing. Yes, so I feel a high threshold for performing genetic testing. Thank you.
So thank you, everyone. So there is still a lot of discussion, but let's move on to the next section. So Ezman, would you like to introduce the next speaker? Thank you
Will
for
do.
everyone. Thank you.
Thanks, Misato. Thank you. And thank you very much to our first speaker. Wonderful talk. We still have a lot of time to discuss on genetics after our second speaker speaks, but it gives me a great pleasure at this point in time to introduce Dr. or Clinical Assistant Professor Khoo Yuan from the National Heart Centre of Singapore. Prof. Khoo is currently a assistant professor in the particular institution with a clinical interest in cardiomyopathy, heart failure, and echocardiography. She's also the deputy director of cardiomyopathy, cardiovascular aging, and longevity program in her institution. But I think more importantly, as she knows I'm very jealous of her, she recently just completed a very wonderful fellowship in HFpEF, cardiac amyloid, and hypertrophic cardiomyopathy at the Bloom Cardiovascular Institute, Northwestern Memorial Hospital, Chicago, in the US. So no better person really to speak on cardiomyosin inhibitors and the future of this therapy. The floor is yours, CY.
Thanks, Ezman, for your kind introduction. So my name is Chun from National Heart Centre, Singapore. Thank you to the organizers for the kind invite. So today I'll be speaking on cardiac myosin inhibitors, the first-in-class therapy for obstructive hypertrophic cardiomyopathy. And these are my disclosures. So I'll be briefly speaking on evidence in myosin inhibitors, where they are in the guidelines currently, and illustrating them with real-world case studies. So patients that we are currently managing in my center. So our first patient, she's actually a 58-year-old lady. She's a bridal makeup artist. So if you look at the red luggage on the top right corner, this is the luggage she has to carry whenever she meets her clients. So she presented to us with recurrent syncope and exertional dyspnea for 2 years. So this makes work for her very difficult. Functional class 2 to 3, and this is her echo on presentation. We can see that her EF is normal. There is SAM with a lot of LVOT turbulence and a bit of SAM-related mitral regurgitation. So on Valsalva, her LVOT gradient, peak pressure gradient was 91. Her blood pressure is borderline, heart rate borderline as well. We started her on a very low dose of bisoprolol and disopyramide, but still she had symptoms, really bad symptoms that limited her work. So she was on maximally tolerated doses of bisoprolol and disopyramide. We discussed septal reduction therapy, but she was not keen. So she was actually one of our first few patients who started on myosin inhibitor or mavacamten, as is available in Singapore now. So what do we know about myosin inhibitors? So for many years, the mainline treatments in HCM has been beta blockers and non-dihydropyridine calcium channel blockers, disopyramide. But all these treatments, they are evidence-based, mostly in observational studies. The randomized trial small in number, and they do not treat the underlying pathophysiology of HCM. They mainly work to relieve symptoms by negative inotropic effect. So myosin inhibitors is the first-in-class medicine that can treat the underlying pathophysiology of hypertrophic cardiomyopathy by working at the sarcopenia level. So they help to normalize the number of actin myosin bridges that are excessive in hypertrophic cardiomyopathy, contributing to the hypercontractility and structural problems in this condition. So there have been several major randomized controlled trials in myosin inhibitors, and across these trials, they have been shown to improve exercise capacity, relieve LVOT gradient, improve functional status, improve quality of life, as well as reduce the need for septal reduction therapy. So we saw that in the Explorer HCM and Explorer CN trial, patients who were symptomatic despite first-line therapy had reduction in LVOT gradient, had improved exercise capacity, improved symptoms, quality of life, as well as beneficial cardiac remodeling seen as compared to placebo. Similar results were seen in aficamten trial, the next-in-class myosin inhibitor, in the Sequa HCM trial. And of course, in the Valor HCM studies, they recruited very symptomatic patients, mostly NYHA class 3 to 4 patients, who were indicated for septal reduction therapy, but who were then given mavacamten. And at the end of just 4 months of treatment, 80% of these patients did not meet clinical indication for septal reduction therapy anymore. Across these studies, we saw that the impact on LVEF was relatively safe medication. Just a small number of patients who had reduction in LVEF to less than 50%, about 5 to 10%. And majority of these patients with reduction in LVEF, they were asymptomatic, and the reduction was transient, with improvements in LVEF when the medication was omitted. So it is no surprise that myosin inhibitor has now been included as part of the latest guidelines in treatment of symptomatic obstructive HCM patients. So in the AHA guidelines, myosin inhibitor class 1 evidence as second line if patients were symptomatic despite beta blockers or non-dihydropyridine calcium channel blockers. And in the ESC 2023 class 2A indication, also as second line treatment. So this is our patient after just 2 months of mavacamten. We can see that the turbulence across her LVOT has calmed down a lot, so has improved a lot. And her gradient has improved. Her peak pressure gradient of Valsalva was 23, and she was at NYHA class 1 to 2 at 2 months of mavacamten. Now, so what about the long-term results of patients remaining on mavacamten, and what are the safety outcomes? So we can see that in the VALOR HCM long-term extension study up to 128 weeks, which is slightly more than 2 years, approximately 90% of the patients continue on mavacamten. 85% of them at the end of 128 weeks actually did not meet clinical indication for septal reduction therapy anymore. And if we look at the graph on the right, at the beginning of the study, 90% of patients were at NYHA class 3 to 4 functional status, but at the end of the study at 128 weeks, actually nearly 90% of them, actually nearly 85 to 90% of them were either at NYHA class 1 or 2 status. And in the MAVA long-term extension study up to 180 weeks, which is about 3 to 4 years, it showed that there was sustained improvement in LVOT gradient, NYHA class, as well as improvements in NT-proBNP. Furthermore, LVEF remains stable long-term up to 180 weeks of study. And what about the real world? So in the RAMS first 22-month study, they saw that there was similar efficacy and safety outcomes seen. So about 4 to 5% of the patients developed EF of less than 50%, requiring temporary omission of the medication. So quite acceptable safety profile. And at 6 months in this real world study, 70% of patients actually had their LVOT gradient reduced to less than 30 millimeters mercury. The most common dose used in the real world was about 5 or 10 milligrams. So this is our patient's latest echo. She remains at NYHA class 1 to 2. She's continuing her work as a bridal makeup artist. Very happy now. She managed to go overseas with her daughter recently. So her latest echo shows that EF remains normal and her gradient remains low, about 9 millimeters mercury. Besides the improvements in symptoms, LVOT gradient, favorable cardiac remodeling has been seen in studies, and this has led to the thought that, hey, maybe mavacamten can have potential disease modification. So in the VALOR HCM trial, they actually studied echo at baseline as well as up to 128 weeks, and they found that there was sustained positive cardiac remodeling in terms of improvements in LV mass index, improvements in diastolic function, improvement in LA volume index, LA strain, as well as RV strain. So another of our patients, she's a Madam P, 78-year-old lady with obstructive hypertrophic cardiomyopathy, NYHA class 2 to 3 on maximal tolerable doses of bisoprolol and disopyramide. So her baseline echo, we can see that there's a lot of LVOT turbulence. There's also at least moderate SAM-related MR. Her gradients were extremely high, peak pressure gradient of 81 millimeters mercury, NYHA class 2 to 3. She was started on mavacamten, and we can see her echo images on the right. EF remains normal. The turbulence across the LVOT has improved a lot, and the SAM-related mitral regurgitation has also improved. And her peak pressure gradient, 6 millimeters mercury, NYHA class 1. Besides that, we also saw some evidence of positive cardiac remodeling in her. So baseline on the right, maximal wall thickness of about baseline on the top, maximal wall thickness of about 2 cm in the basal septum. But if you look at week 36 mavacamten, the images on the bottom, her maximal wall thickness is at 1.5 cm. And besides that, it's quite a dramatic improvement in her ECG as well. So baseline ECG, a typical HCM type of ECG with deep T wave inversions, ST depression in the lateral leads, 1 AVL. But her ECG done 11 months on mavacamten, it looks like the ECG of almost a normal person. So actually all her changes have normalized on the ECG, together with improvements in cardiac remodeling seen on echo, as well as improvements in LVOT gradient. So another of our patient, so Mr. A presented with recurrent near syncope, peak pressure gradient 112, extremely high, baseline echo done in August shows a SAM with a lot of turbulence across the LVOT. And after 48 weeks of mavacamten, we can see that his EF remains normal, NYHA class 1. His peak pressure gradient has also improved. And we can see that over the period of time, there has also been a reduction in LA volume. So his baseline LA volume 85, dilated by LA volume index. At week 36, the LA volume was 78, but still mildly dilated. And actually, we just repeated his echo last month, and his LA volume is now normal. So from dilated LA to normal LA. And this is, so this will be just after slightly more than a year of mavacamten. He also has a reduction in maximal wall thickness. So baseline maximal wall thickness was about 1.5 cm in the basal septum. And his echo last month actually shows that his maximal wall thickness has actually improved to 1.1 cm. Okay, last but not least, this is quite a challenging case of obstructive HCM. She's actually an 86-year-old lady, but of relatively good premorbid. She has obstructive HCM and also decompensated heart failure, NYHA class 3 symptoms. Her legs are always swollen. Her blood pressure is very low. Her systolic blood pressure is in the 80s. She cannot tolerate diltiazem. She can't tolerate verapamil. She can only take a bit of bisoprolol at 1.25 a day. She was unable to tolerate disopyramide because of anticholinergic side effects. And of course, at her age, she was not keen for septal myectomy. So her baseline echo actually shows very high gradients across the LVOT, peak pressure gradient of 86. She has pericardial effusion. At that time, clinically, she was in decompensated heart failure. Her legs were very swollen. But then we couldn't give her a lot of diuretics because whenever we tried to diurese her, her LVOT gradients became worse, her blood pressure plunged. So when mavacamten became available, she was started on it. And the echo on the right, you can see that at week 36 of mavacamten, her pericardial effusion has resolved. Her gradients have improved. Her EF remains normal. We are able to diurese her. She's mostly clinically euvolemic now, NYHA class 2. And she and her family are much happier currently because at least she's able to have walks outside the house with her husbands, etc. And her ECG have also shown concomitant improvement or normalization. So her baseline ECG actually shows LVH by voltage pattern. And at week 36, we can see that her ECG has kind of normalized. It feels like it belongs to a normal patient. So this is our current workflow for patients on mavacamten currently. So we are actually following the FDA guidelines. So for the first 3 months, after getting started on mavacamten, patients will come back once a month for echo, and then we review them in the echo lab with dose titration in the lab. If their dose is stabilized, then echoes every 6 months, and in between, we see them in the clinic about once a year. So how does myosin inhibitors compare with the other second-line therapies? So in this table, I'm comparing myosin inhibitor with disopyramide with septal myectomy. It is actually impossible to compare them because they have not been studied head-to-head before. So this table is just a guide. But in terms of the trials that these therapies were studied in, myosin inhibitors is the one with randomized control trial available, but disopyramide and septal myectomy, mostly observational trials. All 3 treatments have been shown to reduce LVOT gradient, so about 60 to 70% of patients respond to myosin inhibitors. Disopyramide, there's a big range, but perhaps about 40 to 60% in observational studies. Septal myectomy, of course, if it's a successful septal myectomy, more than 90% of patients actually have improvement in gradients. In terms of improvements in exercise capacity or CPET, only myosin inhibitors and septal myectomy have been shown to improve peak VO2, but disopyramide has not been shown to have the same benefits. This was done in a small study. Positive cardiac remodeling has been seen in myosin inhibitors, as we had seen also in our case studies. After septal myectomy, there have also been evidence of positive cardiac remodeling, except in LVGLS. Disopyramide is mainly used for its negative inotropic effect and has not been shown to have any positive cardiac remodeling. What about the challenges in using these second-line therapies? So for myosin inhibitors, our main safety concern will be LV dysfunction, but thankfully the numbers are small, about 5 to 10%, and most of these LV dysfunction, they are transient and asymptomatic. So the EF will normalize after we stop the medications for 4 weeks. And of course, the other thing about myosin inhibitors is the need for echo monitoring and dose titration. Disopyramide, a lot of anticholinergic side effects, especially in the elderly. So a lot of my elderly patients, actually, they can't really tolerate high doses of disopyramide. The other thing, there is prolonged QTC. So usually we do not prescribe disopyramide to patients who have baseline prolonged QTC of more than 500 milliseconds. No formal safety reporting in these observational studies, but so far available observational studies in disopyramide and our own experience is that it's relatively safe. That's true, but we have not had patients coming in for torsades, etc. For septal myectomy, definitely outcomes are better in high volume centers where mortality is less than 1%. But of course, there's an inherent risk of sternotomy operation. You also need expert operators for septal myectomy, which might not be available in all regions or country. So myosin inhibitor currently second-line therapy, but could it possibly be a first-line therapy? So in the MAPLE HCM trial, patients who were symptomatic obstructive HCM, aficamten monotherapy versus metoprolol monotherapy, they found that patients on the myosin inhibitor had better LVOT gradients, had better exercise capacity, had better improvement in functional class, better quality of life, better cardiac remodeling in terms of LA volume index, as well as better NT-proBNP levels in just about 6 months of treatment. So in summary, we have seen that in symptomatic obstructive HCM, myosin inhibitors have been shown to improve LVOT gradient, exercise capacity, and symptoms with acceptable safety profile. So not surprising that it's been established in guidelines as second-line therapy currently. But is there a role for first-line therapy and how would the guidelines change? So I think this will be an interesting space to watch for. And the other interesting space would be the beneficial cardiac remodeling that has been seen in patients started on myosin inhibitor. Does this remodeling translate to clinical benefit? So definitely more studies needed in this field as well, and a long-term follow-up of patients on mavacamten would be interesting to look at. So before I end, I'd like to thank my team at Heart Center because without them, it would not be possible to manage our patients. It will not be possible to see the beautiful echo images that we have seen. So yeah, we have our marvelous echo team, the 3 ladies who help us do the echo for our mavacamten patients. We have our pharmacists and as well as the social workers who help us with the financial aspect, financial help for our patients on mavacamten. And with this, I'd like to end my talk and I'm looking forward to the discussion. Thank you.
Right. Thank you very much, CY, for the wonderful talk. I think a very good overview of the use of CMI, the evidence behind it. We have a few questions in the Q&A chat box. I'll try to order them in such a way that it makes a bit more sense. Probably start with the first question. I will go back to the question about the SCD in a bit. I think it's very relevant to both our speakers. But the first question on mavacamten being used in genotype positive versus genotype negative slash VUS cases. Do you think that genotyping matters, especially in this era of, what you call it, pharmacogenomics, for example? Is there any data that certain genes respond better to CMI, or are we too early in the field at the moment?
I think from the studies currently available, it does not seem that there's any differences in benefits that patients get, whether they are gene positive or gene negative. So currently for patients with hypertrophic cardiomyopathy, their genotype doesn't matter. So we could start them on myosin inhibitors if they need it.
So you will do the gene test, but not really for initiation of CMI, cardiac
Yeah.
myosin inhibitors per se. But just to sort of broaden the question, and this is with regards to Dr. Pasca's question earlier, and this is open as well to Dr. Hiruma and also Prof. Kim as well from Korea. With regards to sudden cardiac death. Now we know that there are certain genes that predispose you possibly to sudden cardiac death. So does this sort of matter in your decision to transplant early, to ICD early? For example, probably start with Dr. Hiruma first.
Thank you for your question. In fact, there is several specific variants, such as some variants in TNNI3 or MIBPG3 variant have been linked to a higher likelihood of sudden cardiac death. But this is not consistent across all sarcomeric genes. In my opinion, the prognosis in HCM cannot be solely attributed by one pathogenic sarcomeric variant, and a combination of the intermediate effect variant and common variant should be needed to determine the impact of genetic background to sudden cardiac death or left ventricular systolic dysfunction, I think.
Fair. And Prof. Kim, do you have any thoughts on using genotyping to risk stratify your patients?
Yeah, actually, basically, I refer to the genetic test, and I consider when the patient has a high risk of sudden cardiac death according to their genotype. I feel like to persuade them more strongly, but to put a ICD to persuade the patients and their families. But in Korea, we have a single national health system, and we have a strict reimbursement criteria, which is not updated recently, and they don't include genotype. So we have only clinical and imaging criterias. For instance, thickened wall more than 3 centimeters, history of sudden cardiac death in their family members, and history of syncope and LV outflow tract obstruction, MRI, LGE, and young age, such things. So that's why I just refer to the genetic test, and then I consider it, but I don't usually directly link it to my clinical practice.
Yeah, I think fair enough being pragmatic and all that. Also, the fact that I think our SCD risk scores are not very updated at the moment. Furthermore, there's discrepancies between the US, the European scores as well. So that needs a lot of updates. And I think, incorporating genotyping somewhere, hopefully in the future, may also help with better risk stratification. The third question in the Q&A box, and I think I'll go back to Prof. Yuan on this, Prof. Khoo, sorry. What happens to LVOT obstruction after stopping mavacamten? I don't know if you have enough experience stopping or you've had patients who defaulted treatment, for example. How long does the LVOT gradient stay normal? Is there a legacy effect like some of medications? And after stopping mavacamten?
No, unfortunately, it's a bit like our GLP-1, where after you stop the medicine, the gradient will come back. But with regards to timing where it comes back, so anecdotally, we had actually one patient with stress cardiomyopathy while he was on mavacamten. After 2 months of the stress cardiomyopathy, here EF and LVOT gradient actually came back again, and she was restarted on mavacamten again. So yeah, I think it's about 1 to 2 months. It's the same period as if we omit the medication where LVEF is depressed. After 4 weeks, the EF will normalize, and usually the gradient will probably come back again.
So a good segue actually, because my next question was going to be about the ejection fraction, which we are holding on to like the holy grail when it comes to deciding on mavacamten, not deciding on mavacamten. My worry is not so much deciding to start it, but to continue on while I see the graphs in the studies sort of going downhill, and probably we don't have enough long-term follow-up, and it seems like it's inevitable that it's going to get depressed. So is there going to be a point where we need to stop mavacamten for most of these HCM patients?
Yeah, so great question. In the MAVA LTE graph, actually, it was quite flat up to 180 weeks. But of course, there's a need to continue echo monitoring because we know that 5 to 10% of patients we may get LVEF dysfunction. And if our patients develop, for example, new onset AF with rapid ventricular rate, if they have some other stressors, it may also cause the EF to be depressed. But I think in general, at least from the long-term studies we have, seems relatively safe so far, and the LVEF safety data is also satisfactory.
Great. I'll open up the floor actually to the other panelists and chairs, Dr. Amano or Dr. Chimura. Do you have any questions related to the second talk per se? Dr. Amano, yeah?
Okay, thank you for a great lecture. I also believe that mavacamten will be the first drug for inhibiting the pressure gradient. But I believe the first step drug will remain as a beta blocker because the side effect is very low and it's easy to use for a patient with young female and has the possibility for pregnancy. On the other hand, the problems of mavacamten, administrating mavacamten is a long-standing medication, and how about the inhibiting the arrhythmic events, including the fetal arrhythmia or atrial fibrillation? And my question is, how about the use of calcium antagonist or disopyramide in the future? So the Japanese doctors are very easy to use disopyramide compared to calcium antagonist. So the position of these two drugs is opposite in the clinical settings. So we seldom use calcium antagonist and beta blocker and disopyramide and use mavacamten after that. So how about in the future, the second line, how do you think?
So how do you think about the future for the second line?
Position of mavacamten, calcium antagonist, and the disopyramide in the future?
Thank you, Dr. Masashi. So you have nicely pointed out that I think personalization of medication according to different patient profile will be quite important because for a young lady who's going to get pregnant, then mavacamten might not be the best medication for her. So I think eventually it will be kind of personalization according to a patient profile. And actually, I feel that myosin inhibitor in the future, it might even be considered as a first-line medication because there are some patients who wants to get symptomatically better faster. So, for example, middle-aged persons who has symptom limiting, who has symptoms that limits their work. For example, our first lady. And then, so I feel that in the future, there's a role for myosin inhibitor as first line. But for second line, I think actually all the rest of the medication will still be useful because in different groups of patients, they might wish to get different medications at different time points in their life or at different symptoms. So I feel that all of this armamentarium that we have is pretty useful and that we could customize it and discuss it with the patients at different points of their life. I would also actually like to ask what have been the experience of using disopyramide and mavacamten in the other countries? How has the experience been?
So I'll just answer first 0. So next. Our Japanese colleagues, I think, probably have a bit more experience. You mentioned disopyramide is heavily used. Do you use it together alongside mavacamten? Do you actually replace one and the other? What do you do, Dr. Amano?
Okay, so regarding calcium antagonist, we interrupt calcium antagonist and add mavacamten, but regarding disopyramide, we use both, and 3 drugs continues a half patient, and the patient with low risk patients, we interrupt disopyramide and add on mavacamten on beta blocker.
I'm not sure if Korea has any experience with using concurrent disopyramide and mavacamten.
We rarely use disopyramide in hypertrophic cardiomyopathy patients, and in Korea, we recommend beta blockers more often, and it is quite common. Patients use beta blocker before use mavacamten because it's also related to our reimbursement criteria.
I think that's absolutely spot on in terms of the gap with regards to HCM treatment in the region. So yes, mavacamten's already here, but with regards to our first line and second line treatments, actually it's all over the place. So I think a good step forward, if Bristol Myers Squibb is actually happy to support, is to find out the survey, the lay of the land with regards to our treatment strategies in Asia Pacific, and then we know how to sort of move forward. But I agree, I think the future is bright for mavacamten, as CY had mentioned. What do you think will take mavacamten? What will it take to push mavacamten up to first line, you think? So you mentioned about the trial. Is that sufficient? Because it was a trial versus metoprolol. Some people have things to say about metoprolol. Some people, as mentioned, use a lot of calcium channel blockers. So do we need a calcium channel blocker trial versus mavacamten before we can actually push it up? What do you think, CY?
Yeah, it'd be great if, like, let's say, we could have a trial where myosin inhibitor is used as first line versus non-myosin inhibitors first line that can be chosen by the physicians. That means, so for Singapore, usually we use bisoprolol, and then we may use calcium channel blockers after and disopyramide after. So it could be according to what the physician feels is most suitable for the patient as first line studied against myosin inhibitor. I think perhaps that may push myosin inhibitors further up, further its course to be considered as first line therapy for
Amazing.
patients.
I like the next question because it was something in my mind as well, but I do know there's a trial going on. And rightfully mentioned by our panelists, we are predominant, I wouldn't say predominant, we have a lot of apical HCM or distal dominant derivatives. So does mavacamten benefit in patients with non-obstructive HCM, in this case being LVOT obstruction, but probably they have mid-ventricular obstruction, for example? So what does mavacamten work for those kind of patients, CY? Or anyone? Really?
For me, I have not started in patients with non-LVOT obstruction because mid-cavitary obstructions considered as non-obstructive HCM in the trial, and in the Odyssey trial that for non-obstructive HCM, it was a neutral trial for mavacamten. So we have not started using that. Intuitively feels like it might help, but I think there is no strong evidence showing that it may help, and patients would not get reimbursements if they chose to get themselves started on mavacamten in this way. So we have not started any patients on that, but I'd love to hear what the other panelists.
Yeah, so our Japanese colleagues first, I guess, Dr. Amano or Dr. Hiruma, any experience with LV, with non-obstructive, but probably mid-ventricular obstruction? Dr. Amano, I guess, yeah.
Okay, thank you. In my opinion, using mavacamten for LVOT, HCM, or mid obstruction is useful, but usage for APH is meaningless compared to the other two because the target event for APH is stroke or lethal arrhythmia by LV aneurysm. So picking up the LV aneurysm by MRI or echocardiography and how to detect the thrombosis is important for inhibiting the cardiac events in APH and not eliminating the obstruction. So the effect of mavacamten is less compared to other two phenotypes, I think.
Great. Dr. Hiruma, have you had any experience?
Thank you for your question. I totally agree with Dr. Amano regarding the utility of mavacamten in apical hypertrophy. But regarding the other phenotype, non-obstructive HCM, the previous large-scale clinical study could not show improvement of tolerance of exercise capacity, but biomarkers were significantly improved. For example, BNP over troponin T, and mavacamten can increase the super relaxed phase of active myosin cross-bridging. So I think mavacamten have potentially merit for a subset of patients with non-obstructive HCM, but we do not have evidence or we cannot identify who can benefit from mavacamten in this population. So for the large-scale study and sub-cohort study is important to detect responder of mavacamten in non-obstructive HCM, I think.
And just tapping into your experience of, genotypes and whatnot, is genotype the answer with this apical HCM subcohort? Do you think there might be a certain type of apical HCM based on genes that may respond to mavacamten, or is this beyond genes?
I'm sorry.
Oh,
pardon,
sorry.
please.
So basically, the question is, you mentioned apical HCM. It might be a bit too broad. So is the answer then genotyping, finding the right gene that maybe would allow mavacamten to respond in this group?
I see. Thank you for your very important question. In fact, the previous study with small subset of clinical cohort could not show no association between genotype and response to mavacamten. But it is limited to very small cohort, and preclinical study using mouse model with thick filament variants or thin filament variants showed distinct response to mavacamten. So further investigation with a more large-scale study may have possibility to describe different response to mavacamten based on according to the responsible gene. I think.
Great input. And Prof. Kim, so in the event of mid-ventricular obstruction, do you run to mavacamten or do you look for other sort of treatment options?
Yeah, on pure mid-ventricular hypertrophy, it's not reimbursed as Professor Khoo mentioned, but I have an experience that patient has both mid-ventricular and left ventricular outflow tract obstruction, and they both improved, of course, after the use of mavacamten, and that's the clue for the evidence that we can that can be a clue that we might use mavacamten, and that might be helpful in those patients. But we need more evidence.
Yeah, fair enough. And I think it is patient selection at the end of the day, and really a trial dedicated to MVO, ventricular obstruction, would be useful. The last question is quite interesting because I think in the era of heart failure with reduced ejection fraction, where we have a lot of evidence-based guideline-directed medical therapy, there's a lot of things to be said about, ICD implantation, whether we should be delaying it. And I think the guidelines are being updated at the moment with regards to the position of ICD, the recommendation of ICD. Do you see that also happening because mavacamten is now in stores? Prof. CY.
I think too early to say because although we have seen some positive cardiac remodeling, but we do not know, there's no evidence of the benefits long-term downstream. So mavacamten strictly indicated for symptomatic LVOT obstruction. It is not indicated purely to reduce sudden cardiac death risk or arrhythmia risk. But I think it'd be an interesting space to look at the long-term studies. But I think too early to tell. So I would not base any sudden cardiac death risk decision on whether or not the patient is on mavacamten.
Fair enough. And it's a bit too early to extrapolate, as you mentioned. Dr. Chimura, do you have any questions for our panelists? Go ahead.
Thank you so much. So my question is very basic question according to safety concern. So what is the key safety concern when using mavacamten? So, and how should clinicians monitor patients in routine practice except for echocardiography?
So I think the main safety concern is LV dysfunction. But unfortunately, I think for now, the main modality to monitor for that will be echocardiography. So we are currently following the FDA protocol. I think in the future, maybe with the many AI stethoscopes available, etc., maybe there might be a role. But for now, I think LV dysfunction is the main concern, and echocardiography remains the most established way of checking LVEF. So yeah.
I mean, good answer. Actually, good question because I saw your protocol for National Heart Center, and at the end there's something about GLS assessment. So is GLS assessment there for the mavacamten, or is it just part and parcel of your HCM 3-5 yearly sort
Ah,
of assessment?
So our echo lab is pretty good. So for patients with thick LV wall, most of our sonographers are doing GLS assessment.
Okay.
Specifically for patients on mavacamten, I wanted to add GLS in just to have a comprehensive view on how's the myocardium improving, whether or not there's any positive remodeling. So I put it there as as kind of like a reminder to ourselves.
It is also part of the protocol, am I correct, with the major trials to assess GLS as well? Can't
Uh,
remember, to be honest.
there was some GLS improvement, so I guess that they check
Yeah.
GLS as well in the major trials. Yeah.
Yeah, so it should be part and parcel though.
Mm.
There are no more questions in the Q&A box, but again, open up to the panel. We still have a bit of time. Again, very rare to discuss about mavacamten and HCM. Prof. Kim, do you have any questions?
I was just going to ask for the mid-ventricular obstruction, but it's already handled. So I'm curious whether the Asian population, in the previous studies, they use mostly 5 to 10 milligram, but Asian population, we have smaller body size. So maybe we might need lesser dose of mavacamten. So what's your opinion on that?
For our center so far, actually, the most frequent dose is also 5 or 10 milligrams. And I think in the Explorer CN study, although they started their cohorts on a lower dose of mavacamten 2.5, but eventually, actually, most of their patients are either on 5 or 10 milligrams. So I think the effect of mavacamten is beyond BMI. So even though Asians have smaller BMI, increased numbers of poor CYP2C19 metabolizers, but overall, it doesn't seem to affect the dose of mavacamten that we can use in our population. Yeah. So currently our starting dose of mavacamten is still 5 milligrams. Is it the same in Korea and Japan?
Yes, we do same.
Okay.
All right, so if there are no more questions, actually, then we're just sort of 5 minutes ahead, but it's absolutely fine. Just checking one more time. Right. Thank you very much, everyone, for tuning in today to this wonderful episode. I'd like to thank my co-chair, Dr. Chimura, all the way in Edinburgh, for helping me chair this session. I'd like to thank both our panelists, Prof. Kim and also Dr. Amano, for helping troubleshoot a lot of the important questions as well, both on genotyping, HCM, and also on the cardiac myosin inhibitor questions. And definitely, without doubt, thanks to Dr. Hiruma for the wonderful talk on genetic architecture. I think I've never seen a talk on genetic architecture in HCM, so this is my first, and I'm very wowed by it. So wonderful. And Prof. CY as well, thank you very much for your talk on cardiac myosin inhibitors, and really thank you for all the real-world sharing of the use of the drug, because it becomes more applicable when you use cases and actual patient cases. Just a bit of a reminder, our next episode is on the 18th of March, which will be on electrophysiology and arrhythmias. We have a star-studded panel, so you don't want to miss that out. And again, a bit of a shameful advertising here. Don't forget to join us in Taiwan, Taipei, Taiwan, in May for our APSC Congress as well. So thank you again, everyone, and have a great night ahead. Thank you.
Thank you.